So our last speaker is Sonia Afanasiova, who is a speech-language pathologist at the MUHC, where she's worked since 2021. She earned a master's degree from the University of Ottawa in 2020. Her experience working with the head and neck cancer, Dysphagia Clinic, stroke, neurology, and tracheostomy teams has shaped her practice and deepened her passion for interprofessional and intraprofessional collaboration. At the MHC, she conducts communication and swallowing assessments across a variety of populations, including critically ill patients in the ICU. Alongside her colleagues in the SLP department, she co-authored a book chapter on managing swallowing disorders during laryngeal cancer treatment and launched a peer committee to develop a protocol for using expiratory muscle strength training with head and neck cancer patients. Sonia hopes to continue having opportunities to exchange knowledge and insights with colleagues from various professions, further enriching her practice and fostering collaborative care. Sonia will present on communication with ventilated and tracheostomized patients. Welcome, Sonia.
Will the sound from my videos work? Or do I have to click on something to share? Do you want me to check? Should be fine? Okay. Okay. So hi everyone, my name is Sonia. My presentation is called Clearing the Air, Communication Beyond the Vent. I've already been thoroughly introduced, so I'm not going to do that. Today, this is going to be the structure of the presentation. So basically, we're going to go through what is communication, why communication can be challenging specifically for our ventilated and trached patients, as well as some solutions that we can find to help these patients communicate, such as using AAC, using different kinds of speaking valves and trachs. And then we're going to talk about additional challenges specific to the neuro population that can make using AAC or speaking valve or any other more classic solutions extra challenging. So communication is defined as the act of transmitting a message from person A to person B. And this can be done in a variety of ways, whether we're pointing at pictures, whether we're gesturing, whether we're actually talking, texting, email, writing, anything you can think of that communicates a message is communication. In general, we do recommend that the patient hear you and see you and communicate in the same language as you. So for that purpose, if they have glasses, they should be wearing them. The lights should be on. They should be wearing their hearing aids if they need them. Otherwise, we have pocket talkers available in our department to help them hear a little bit better, which is like a little mic that you speak to, and then there's headphones that go on the patient's head. If there's a language barrier, it's always best to have a translator at bedside that you can speak through. There are also translation apps that are available. We actually do end up using Google Translate quite a lot. All of these systems have their own limitations. And there's also bilingual picture boards that you can use. So there are various reasons why working in acute care can cause communication to be more challenging, but also it's more important than ever. It's more important because patients are going through a stressful time. They might need extra counseling. They might need extra support. They might have more things to say. They might have more important conversations to have, but this is all happening while they may have a physical impairment, a communication impairment. They might have an alternate level of consciousness. They might be delirious. They might be very stressed, and that can make communication more challenging. This is a quote that I really, really liked that I found. This is a nurse talking, and she said, "The person should not be hungry, wet, or thirsty, but there are other needs, holistic care, psychosocial needs, And she said, I could imagine on some of these levels, a person who cannot speak would find it harder to progress. And I really like this quote because it really spoke to the fact that communication is essential also in the rehab and medical side. However, nurses found that it was extra challenging to communicate for a variety of reasons. They found that time was an important factor, where it can take a little bit longer to communicate. It would be more frustrating. If the patient has a very specific way of communicating, sometimes during shift changes, telling the other nurse what system exactly you might have used can be challenging. And then also lack of resources. So maybe you don't have enough picture boards, alphabet boards, all of these things that you can try at bedside. So let's jump right into it. What is ventilation? It's, as you know, when a person needs an outside source to breathe for them. This can be required because of trauma, because of sleep apnea, respiratory failure, neuromuscular disease. It could be for a surgery. It could be because they have an airway obstruction, such as a tumor in their throat or maybe a vocal fold paralysis that doesn't allow the air to go through the upper airway. Ventilation could be temporary or permanent. It could be invasive or non-invasive. Invasive ventilation can happen through endotracheal intubation, so the tube going in the mouth, or via tracheostomy. When a patient is ventilated for more than a certain amount of time, they would require a tracheostomy in order to increase their comfort, in order to facilitate oral care, to facilitate communication, swallowing, and to avoid laryngeal injury. So the trach, as you know, it's inserted below the vocal folds, and the patient becomes a neck breather. So they breathe in through their neck and they breathe out through their neck. When they have a trach and they're connected to the ventilator, the type of trach that they have is a cuff trach. So you see the little bubble around the trach on the picture on top. And this bubble allows the system to be closed. So there's no air leaking up through the upper airway. Through the weaning process, what happens is we start trying to see if the patient is able to get the air up through the upper airway. So what happens then is that initially the cuff is deflated. This would allow for some air to circulate around the trach. And when it goes up, the air will go through the vocal folds, which are above the trach, which will vibrate, creating a sound wave. And then that sound wave will be shaped into speech by the articulators. So the articulators being the tongue, the soft palate, the lips, the cheeks, and so on. Then, if cuff deflation is tolerated, the patient will be switched to a cuffless trach. The cuffless trach will allow for even more air to circulate around the tracheostomy tube, and the patient will be able, hopefully, to have a voice that's even stronger. At this point, when they're tolerating cuff deflation or they have a cuffless trach, they can either speak with just this voice going around the trach, or we can start trying other strategies. One example could be putting your finger on the trach and blocking the air going out to redirect the air through the vocal folds. And that would allow them to have a stronger voice because there's less loss of air through the neck. And at this point, we might also want to try a speaking valve. So the speaking valve assessment is done by an SLP. I wanted to take a little detour and talk about the inventor of the speaking valve. The inventor of the speaking valve is David Muir, who invented it for himself because he needed it at the age of 23, I think, because he passed away, unfortunately, at the age of 28 in 1990. And he talks a little bit about why he wanted to invent this. And I hope the sound works. Yeah, and the video. Yeah. Should I click on YouTube here? commercial job. Is this loud enough? Yeah. Yeah. This is max. Is there something else? So it's super interesting because David Muir was on a ventilator. So, and he was quadriplegic. So he wasn't able to actually invent the speaking valve by writing a patent or by saying it. So he did have to go through a lot of assistance using alphabet boards, using things like that in order to actually create the object he wanted to create. And now it's used everywhere, which is pretty cool. I just don't know how to get out of this, Gabby. Thank you. I do have quite a few videos, so I don't know if are they all videos? Yeah. Okay. They have like aphasias and dysarthria. Did the sound work in the Zoom? Yeah. Okay, perfect.
Nope.
No, it's not. I think I'm the other one. Yeah.
Okay.
Okay, perfect.
Hold up. I gotta put you back on full screen. But yeah, this will have to happen.
Thanks, Gabby. So the speaking valve, the way that it works is it's a one direction valve. So it's placed on the trach. And what happens is that when the air is breathed in, when the negative pressure from the lungs will open the valve and the air will come in through the neck. However, when the patient is breathing out, the positive pressure from the lungs will close the valve and the air will be redirected through the upper airway, as we see on the schema over here. It's the benefits of the speaking valve are, on one hand, for communication. So it can help the patient have a stronger voice than what we would just see with leak speech, because there's no air loss through the neck on expiration. But also because there's now air going through the upper airway, it restores sensation, taste, smell, which can... Yeah. Oh, it's okay. And the fact that the air is flowing there can really help with the patient managing their secretions better, having a better cough. It can help with swallowing as well. So it's a good tool for communication, but also a good weaning tool for on the trach and vent pathway. The other thing that's important to know is that because breathing in happens through the neck, there's no humidification that is possible. So with the cork, you don't need a high humidity source. You do need it with the speaking valve because it's not humidified by the mouth and nose. The speaking valve is also a tool that's available with the ventilator. The way it works with the ventilator, it's connected through the tubing. Because we do need the air to escape through the upper airway, the patient would need to tolerate cuff deflation at this point. And there is a video over here. I don't know how hard it's going to be. Do you want to try it in here?
Yeah, we'll try it. We'll just also have to make sure Mondays that we have to share the
sound. Yeah.
So you see how it says share sound?
No.
Yeah, there's a little tick box.
Yeah. Yeah. Guys.
Departments understand our business and reach our goals.
So, project management.
No, we're
Count for me, Tammy.
So we see over here that Tammy has no voice. There's nothing that's coming out. We see her lips moving, but nothing's
Okay,
working.
good try, good try. So we'll pop the speaking valve on. All right, can you try that again now?
1, 2, 3, 4, 5.
How's that?
So at this point, the ventilator is breathing for Tammy. Her cuff has been deflated a little bit or all the way. There's been an adjustment made also on the ventilator settings to compensate for the loss of air through the upper airway. So this is an assessment that happens jointly with the respiratory therapist and the speech language pathologist, and usually a nurse or a doctor present as well. So once the patient can tolerate the cuff being deflated, we can also see if they can have leak speech like they would with a trach. But then we can also try the speaking valve, which is, as you saw, placed through the tubing. The perk just for like the speaking valve on a trach is that it does help with weaning, and it is a little bit of a rehab tool because you have to push harder. So it does facilitate lung recruitment. Another way to have a voice while on a trach is to have a special kind of trach, which is called a talking trach. So above cuff vocalization, the way that it works is the special tracheostomy. It will have an additional port that goes on top of the cuff. On the one hand, it's going to allow you to suction for the secretions from above the cuff, but also you can inject air through that port, which would allow you to have a source of airflow and to have a voice. So we have another video with Tammy. Yeah, maybe it works this time. I don't know why it didn't work.
As the RAM just isn't there.
I mean,
We're going to try this technique called ACV, which is above cuff vocalization. And it's a way that we can help you to speak using your voice, even though this balloon on your tracheostomy tube, the cuff, is up. Okay. I'm just going to check there's no secretions there before we start.
So we see her using the suction port to
Nothing
take the
at all.
secretions out.
So we're just going to attach this just onto this oxygen here.
Now she's connecting the oxygen source
Hopefully we'll get your voice.
for the airflow.
Louise is going to attach this, and what it's going to do, Tammy, is blow a little bit of air above the tracheostomy through your vocal cords.
Just going to start turning the oxygen on now, Tammy, okay? I'll gently be putting my
She's
thumb over
controlling the
this
airflow with the thumb.
and you'll start to feel the airflow. So I'll do it nice and slowly.
So we go to a maximum of only 5 litres of air, so we want a gentle airflow. Tammy, can you try and count for me?
1, 2, 3, 4, 5.
I'll stop the video here. Actually, it's really interesting because David Muir, in the interview that we saw earlier, he talked about having had this kind of trach before and how he didn't like it because it really dried up his throat to have that airflow going through. I don't know that there are fixed protocols for the use of this kind of trach as well. So I think there's some discrepancies in the way it's used in different places, but it can be a very useful tool, especially for patients who are on the trach for quite a while and who have a lot of secretions above the cuff. The issue with it also is that it does take quite some coordination and does require a lot of monitoring and quite a team. And once again, we see that this is a multidisciplinary approach where the respiratory therapist, the nurse, and the speech language pathologist are all working together to help this patient communicate. Another option is an electrolarynx. So I'm sure you've seen these. I brought one with me. The way that it works is that the electrolarynx is an external vibration source that you can place against your cheek or against your throat. It's going to vibrate like this. It's not loud enough. So you do need to mouth quite clearly when you use this, and it does require some coordination. So a patient would need to press on the button as they speak. For some patients, it's very easy to learn. For some patients, it's a little bit more challenging. So it does require a speech language pathologist to teach the patient how to use it and to practice with them. Now that we went through the ways that we can have a voice, there's also a lot of communication options that don't include a voice that I'm sure you're using all the time. So asking yes/no questions, inviting the patient to mouth, so moving their lips without making any sounds, and using different kinds of alternative and augmentative communication. We also use all of these at the same time, usually. It's very rare that we only use one way of communicating. So yes/no questions might be the most obvious one that we often use with ventilator and trach patients because it's probably the quickest way to do your routine little communication questions. So asking if the patient is tired, if they have pain, if they need to be changed, if they need the bed to be adjusted is pretty easy through yes or no questions. It's important to make sure that the patient has a different way to say yes and to say no, because otherwise it can become very confusing. So the only limit to this is our imagination. As long as the patient has two different symbols that they can use, so looking up and looking down, wiggling their fingers and puckering the lips, all of these are good as long as it's staying consistent, it's communicated between shifts. And it's also important to make sure that the patient is understanding your questions, that they're hearing you correctly. The limitation of this system is that every question is invented by you. So the patient can't really initiate communication. They can't really tell you about a problem they're having. So very quickly, as you know, you can run into more frustration because you're not quite catching what it is that the patient wants you to ask about. So some tips are, we're to mouthing now. So something else that the patient can do is move their lips without the voice. So what we can encourage the patient to do is to speak slowly, to exaggerate the movements of their lips and tongue, to focus on key words. You might want to also mix it up by adding yes or no questions to make sure that you understood correctly, that to clarify the topic. And you can also ask them to point out the first letter, for example, on an alphabet board, which could be an additional way of combining those different voiceless communication options. Alternative and augmentative communication is a large spectrum that goes from the lowest tech to the highest tech. We might think of a picture board, such as this one that you probably saw in the ICU. You might think of the alphabet board like this one. There's also assisted boards where you're tracking the patient's eyes and seeing where they're looking and asking yes and no questions. And you have like two sides to the board. You also have assisted alphabet boards where you would ask, oh, is your letter in the first row? Is it in the second row? Is it A? Is it B? So there's a lot of different options for AAC. The trade-off is always that when you have a system, it can either be very efficient, so the patient can express their message quickly, With the picture board, for example, they can very quickly tell you that they need a pillow. However, if they use the alphabet board to tell you the same message, it might take you 5 times as long. However, with this, they can communicate a total of 20 messages. That's all they can say. With this, there's an infinity of messages that they can communicate. So it's always a trade-off of efficiency versus specificity and variety of messages. On the longer term, you can also get more complex devices. I don't think we need to see this video, it's okay. But this is a gentleman who uses an eye gaze system where he has an iPad with a camera at the bottom that tracks the movement of his eyes in order to select letters and specific messages. This kind of system is elaborated in tandem with the SLP. It's very, very personalized. It takes a lot of practice to learn. So, yeah, I do think I want to show you this one. Sorry. I know I have a lot of videos.
Oh, no worries.
I switched from due dates to due dates, and it made me go from weeks behind to weeks ahead of my deadlines. You see, I used to just bed rot all day getting nothing done.
So I like this video because it's actually a nurse using a communication
Sure, I'm Nick. I'm the
cart.
nurse that's going to be looking after you today.
And the communication card
getting
that you
on?
see by
Some
the nurse's
patients
side
need
contains
specialist
different
assessment if they've
strategies
got an
that
underlying communication difficulties. If they've got neurological problems, say they've had a head injury or head and neck cancer surgery. But many patients with tracheostomies actually just need some simple strategies that the nursing staff can use, the physio, anyone in the MDT who's working with the patient. There are lots of different very low-tech tools that we can use for communication. It might be something as simple as a pen and pad. But there are also a range of communication charts, pictures or word-based charts, alphabet charts, an iPad. There are some fantastic apps now. Sometimes patients like to use just one method for communication, but patients who are a bit more unwell with a tracheostomy might vary through the day in terms of their fatigue. So it's good to have different tools available to try at different times. Having everything on one trolley allows the nurse to sort of try different strategies with the patient. So often you see a patient struggling to mouth words or get their message across, and you can see a pen and paper on the other side of the room. So it's just a little bit of thought about having those strategies.
Thank you, Gabby. So what I really like about that video is you really see the nurse trying to use different methods. We saw that he tried to use the erase board and that didn't really work. It seemed like the guy's hand was maybe a little weak for writing. They had the yes/no cards. He encouraged the patient to mouth clearer, which seemed to be helpful. And really this sort of stepping up and stepping down and combining different kinds of AAC is very helpful to support the patient's communication. If there are specific boards that you feel like your patient has specific messages that they're trying to say once, again and again, it can be something that the SLP at your hospital can develop with you. And doing an SLP assessment can really help choose the best and most specific AAC that's most helpful for the specific patients. Some patients want to have the opportunity to say anything they can. Other patients really want to go quick and not waste any time. Everyone's different. There's no one size fits all, and working together is really the best way to figure this out. So for the neuro populations, there's many additional challenges because as we know, our patients may have impaired language centers, impaired cognitive centers. They might have motor speech disorders, and they might have reading and writing disorders, which can further impact the way that you can support them. For example, they might be aphasic. So aphasia is a language disorder. So it's a difficulty communicating that occurs because of damage, usually to the language centers of the brain, which for most patients are situated on the left side. It's different from a cognitive deficit. It's different from confusion or delirium, although these things can all occur at the same time. So it's very important to assume competence for our patients. There are different kinds of aphasia. One kind is a fluent aphasia. We'll watch a video here. Sorry, Gabby.
Why did Amazon send me $20,000? Because I use Amazon AI. I'm going to show you.
The neuro to pay for Prime.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
With the iPad that we were doing. Like here?
I'd like my change.
So we see that Byron is able to talk in a very fluent way. However, there's not much content.
Hi, Byron. How are you?
I'm happy. Are you pretty?
Now it's
you
working.
look good.
What are you doing today?
We stayed with...
However, we also see that Byron has some trouble understanding the questions that the speech therapist is asking him. He's really responding with things, even though what he's saying doesn't really answer the question, we can also tell that he's not understanding it because he's looking the other way. She's asking about the iPad and he's clearly looking outside the window, thinking that she's talking about something there. So these are patients for whom the relative strength is the fluency of their speech and the relative weakness is their understanding.
For them at the moment?
Sorry about that. There are many other types of aphasias. Sorry, no, it was the previous one, yeah. Another type of aphasia would be a non-fluent aphasia. The non-fluent aphasia is mainly characterized by a difficulty to get words out, with understanding being a relative strength. There are certain skills that you can learn and that you can use to help patients really reveal their competence and reveal how much they understand and how much they have to say. And this is a video that illustrates this very well. Maybe. Not quite. So this is this gentleman talking to the speech therapist, and she's asking him open-ended questions. She's
What
not
sort of house do
using
you
any
live in?
strategies.
Where do you come from?
She says, "Where do you come from?" She's really not supporting him at all. And you can see that he's trying, but the message is not really coming out. So let's see what happens when the therapist uses some strategies.
Okay, I wondered if you could tell me a bit about where you live, Simon. Does that map help, or you want to try this one? Okay.
Yes.
Wallingham. Okay, that's an area I don't know very well.
No.
Actually. Have you lived in Wallingham a long time?
Yes.
How long? 5 years?
No.
10 years? 14 years?
Yes.
14 years in Wallingham?
Yes.
Why have you picked Wallingham? What's nice about Wallingham?
No idea.
You don't know why you chose it?
No.
Was it for any of these reasons? Was it because the schools were good?
No.
No? Or good shopping?
No.
To do with your work? Where you needed to be for your work?
Possibly.
Yeah, possibly. So, your house in Wallingham?
Yes.
What's it like? Is it detached or semi-detached?
Yes. Hemi-detached.
Semi-detached.
Yeah.
How?
So we see that therapist here is using many strategies that are helping this specific gentleman get his thoughts across. Aphasia can have varying degrees of severity, and that can be as much for auditory comprehension, so they might understand shorter sentences but not longer ones, as much as for verbal expression. So maybe they're not able to get any words out. Maybe, as we saw with Byron, the words come out, but it doesn't make any sense. Every aphasia is different, and there are specific strategies that you can learn for every patient. These strategies are developed by the speech-language pathologist during their assessment. So really working together can help us communicate best with these patients. If we go back to the ventilated and tracheostomized population, imagine this person with this pre-existing set of challenges related to their respiratory condition, on top of that having an aphasia. So what that could mean is that some of these strategies that we tried to use before would not work anymore. For example, they might not understand the symbols on your picture board. With a very severe aphasia, you could have difficulty linking a picture to a meaning in your head. They could have difficulty understanding the questions that you're asking them if you're trying to go with a yes-no system. Once they have a voice, if they can have it, it's possible that they want to say one word and another word comes out. So it's very important to make sure that the communication system that you're using is adapted to this patient. This diagnosis is written by an SLP in their assessment. So once again, working together is the best way to support our patient's communication. The other thing that we noticed in the video is that the gentleman was not using his right side. Aphasia usually is associated with left hemisphere damage. So with most people being right-handed, this can affect their dominant hand and their ability to write, for example, or to point at pictures well, or to gesture. So that's another thing to keep in mind. Another type of communication disorder is a cognitive communication disorder. It's different from aphasia because whereas aphasia is due to damage to language centers in the brain, cognitive communication disorder is related to damage to cognitive faculties in the brain. This cognitive damage will impact the patient's communication. For example, if their attention is impaired, well, then they're probably going to have trouble listening to you and attending to what you're saying, which might impact their ability to understand the questions that you're asking. Even though there's no language deficit, they still don't understand you. It might impact their ability to process the information that you're giving them. So they might have trouble understanding when you give them a lot of information at the same time, or it might take them a little longer to integrate it. They might have trouble attending to the left side. This is something that we see a lot, hemi-neglect with right-sided stroke. This can impact their ability to talk to you when you stand on their left side, their ability to look at the left side of your communication board. They can also have impaired nonverbal communication. So maybe they're not responding with facial expressions as much as you want them. They might have a flatter affect. They might not look at you as much. They might have trouble understanding jokes. They might have trouble understanding indirect instructions. Their social communication can be impaired because they're not reading the situation as well. So maybe they're interrupting you, maybe they're making rude comments. Usually, cognitive communication disorders occur from damage either to the right side of the brain or from diffuse damage. So this can happen after a stroke, with a brain tumor. It can happen with a traumatic brain injury, and also neurodegenerative disorders. As I mentioned before, this can also impact our communication with the ventilated and trached populations because they might not attend to the left side of your picture board. They might not attend to the questions that you're asking. They might forget the topic of the conversation. It might take them a little longer to learn a system if they're able to do it. So for example, if you have a complicated communication system that you develop with this patient, maybe they won't remember how to use it the next time. Maybe they won't remember how to use it 5 minutes later because the verbal information provided is not sticking in their brain. There are also motor speech disorders that can impact communication. So if you think about the sequence of sending a message out, the message is formulated. It's sent from the brain to the muscles in the face. When you have apraxia of speech, the issue is not so much with creating the message or really moving the muscles as much as it is an issue with sequencing the movements of the tongue, of the lips in order to talk. So these patients, you'll notice that they'll have trouble starting to talk. You'll notice these groping movements. So the lips moving repeatedly before they start talking. Their errors will be irregular because it's not related to a specific weakness anywhere. And you'll notice that they'll have more trouble the longer their utterance is because it takes more coordination the longer you talk.
Gina, I am 43-year-old. I have praxia speech.
Okay. Did this super quickly. So we saw that this lady, we really saw all of the things that we listed previously. So she has trouble starting to talk. The errors are not the same. It's not always M's or P's that she's having trouble with, for example. And if we think again about our trached and ventilated patients, how this might impact them is, for example, they might have trouble initiating phonation if they're eligible for a speaking valve. They might have trouble starting the voice. They might have trouble mouthing well, so moving their lips and tongue if they don't have a voice. When you have one type of apraxia, such as apraxia of speech, you might have other types of apraxias that come along with it. So maybe they have trouble gesturing in order to communicate. Maybe they have trouble pointing. And once again, apraxia is usually associated with left hemisphere damage. So that would be an impaired dominant side for a lot of our patients. Oh. Oh, there we go. Okay. Another type of motor speech disorder is dysarthria. This one is really related to the movement of the structures that we use for talking. So that could be coordinating breathing, moving your vocal folds, moving your tongue, moving your lips, moving your soft palate. There are different types of dysarthrias which are associated with different lesions, and they all sound different. The gentleman on the bottom has unilateral upper motor neuron dysarthria, and he has it maybe because of a stroke or a brain tumor, but there's definite damage to one side of his brain, which impacts the contralateral side of his face. We see that his lips are drooping a little bit. We see his nasolabial fold that's a little bit flattened on that side. And we can imagine that there's also the same weakness or spasticity, maybe, on the same side in the throat, which would impact his voice, because maybe the vocal fold is not moving as well. His voice would be maybe a little bit breathier. He would have trouble speaking very precisely. And the lady on top has a different type of dysarthria. And I just want to show you how different types of dysarthria sound.
Voici Max. Il a décidé de cuisiner plus.
Okay, man. Okay, she's repeating, my baby ate a cupcake on the train. Say it one more time.
My baby ate a cupcake on the train.
Okay.
So this is a very different type of dysarthria than the one we could imagine the gentleman on the bottom would have. We hear that it impacts the way that her voice sounds. Her voice is very strained. It's very rough. We hear that there's a lot of air escaping through the nose. She sounds a little bit hypernasal. Her articulation is also imprecise. The two dysarthrias that I mentioned before are associated with vocal changes in some patients. So a dysphonia, but a dysphonia can also occur on its own without the dysarthria. For example, and this is very relevant for the population that we're talking about, intubation injuries can occur, which can impact a patient's voice. So on this video, and you actually see it just from the, I don't know if it's going to play quickly. Okay, perfect. On the video, you're going to see a granuloma that occurred because of intubation. So there it is on the left vocal fold. You really see it there. And you can imagine that as the patient will be trying to voice, they will not fully close because of the presence of that mass there. So there's going to be air escaping. So the voice is not going to sound as strong. It's going to sound pretty breathy, maybe a little bit weaker. So that's for ENT to decide. It would really be a good time to consult ENT if you suspect that your patient has an intubation injury. So dysarthria and dysphonia can impact communication, as we can imagine, for our patient population. For example, they might have a lot of trouble using a speaking valve because their vocal folds are just not working as well. So even if the air is blowing through them, well, you might not be able to hear that voice, or it might not be strong enough for you to understand what they're saying. With some types of dysarthrias, you might also not have very good mouthing ability because your lip movements are weaker. Maybe your tongue is not moving as well. So if they don't have a voice and you're just trying to read their lips, it might be extra challenging for these patients. For some patients, it can even impact nonverbal communication because their facial expression is a little bit fixed because the muscles don't move as well, or they move very little. There are also reading and writing disorders that are also communication impairments that can occur. Reading and writing disorders, called alexia and agraphia for writing, are associated both with aphasia and cognitive communication disorders, although they can also occur on their own. So a patient might be able to communicate very well verbally, but writing and reading might be impaired, although this is less frequent from my understanding. At the very top, you have a picture from a study where a camera was tracking the person's eye movement while they were reading a text, and you can see that they're only attending to the right side of the paragraph. This would probably impact their ability to really understand what the text says. There are many different types of alexia. This is one, which we can suspect is related to a cognitive communication disorder where the patient is inattentive or neglectful of the left side. But it could be also due to processes more related to language. So for example, the patient could see the letters D-O-G and read out cat. So that's a different type of alexia. At the bottom, you have an example of agraphia. So this is actually a patient here at the hospital who wrote a thank you note to my colleague Tina. He wrote ganks, crossed it out and tried to write thanks on top. And this one was associated with an aphasia. So we can see that there's different types and different reasons for which a patient might have trouble reading or writing. As with every other communication disorder that we talked about, these things occur on a spectrum. So maybe your patient can read words, but not sentences. Maybe they can write their name, but not write a text to their family. The way that this could impact communication with the vent and trach population is obviously maybe pen and paper is not a great solution for them. Maybe giving them a topic list as an alternative and augmentative communication system might not be a great system for them. So this is also where the speech-language pathology assessment would be helpful and where we can work together to figure out the best system for our patients. So that's it. The take-home message that I would like for you to remember is that there are specific challenges associated with trachs and vents. For the neuro population, this often overlaps with specific neuro challenges in communication. There's no one-size-fits-all solution, which is why we work better as a team. And often nurses are closer to the patients. You interact very frequently with the patients. You know exactly where communication breaks down and what messages it is that the patient is trying to get out, but also what messages it is that you are trying to get in. And we have the knowledge to help you out with that. So working together is the best way to help our patients communicate better. That's it.
I will read out a question from a virtual attendee. So I know that Neuralink is conducting some BCI trials in Toronto. Are there plans to involve the neuro in these innovative communication technologies?
That's a great question. I don't think it's relevant on the inpatient side, which is really what we're talking about, because any type of more complex system would require a lot of adaptation. Yeah. It's very personalized, so it's more often done in the outpatient setting. I'm not aware of any collaboration right now, but that sounds super interesting. And if anyone wants to collaborate, they can write to me. Here's my email.
Just a few details about Neuralink. This is something that has been discussed among some clinicians at the Neuro. Just something to keep in mind that all clinical trials are conducted by the clinical research unit here in the building. So that information was passed along to our McGill friends on the other side of the building. But that's the last I've heard.
Any other questions? Okay. Thanks so much. Thank you.
Thank you.
Back up my props.
So thank you everyone for your time, attention, energy. Thank you for being here. Thank you for, asking questions and so on. I will pass it on to Maxime, who will give the closing remarks for the conference today. Thank you, everyone. And please fill the evaluation form so we can structure future events. I see a lot coming in already, but please be descriptive. Okay, thank you.
Thank you so much for allowing me to speak at the end of the conference. this takes a lot of time to plan these kinds of events, even though it's just one day. Booking all the speakers, going through the logistics, finding sponsors for food, making sure that there's variety in the program. That takes a lot of time. So thank you, Maria, and thank you, Gabby. Thank you as well to everybody who contributed. We had amazing speakers. I think we had a wide range of topics that were discussed today, all very relevant to nursing practice and or neuroscience. It is my wish that we have more of these events in the future. And as I said this morning, if you're not a CAN member yet, please consider joining. You're going to have access to membership on the Medical Association, as well as access to all of the online events that other CAN chapters put together. We're a vibrant association. It's about 200 members coast to coast to coast. And sometimes in your practice, you might want to reach out to somebody in another province who's doing things maybe a bit differently, or they haven't the same field of expertise as you do. There's a Slack, I don't know if people still use this, but we have a Slack channel for CAN members across the country where you can just ask a question and somebody maybe in BC is going to answer you, maybe somebody in Saskatoon or in St. John's. And it's a very close community in neuroscience nursing. So there are definitely benefits to being a member. So I hope you enjoyed the day. Thank you for coming out.
And thank you, Max, for supporting us.
Thanks for pushing the conference. We appreciate it. And all the presentations were recorded today. So if you had to step in and out, don't worry. I will share the recording with the virtual participants, the in-person participants, if you want to look back at anything. But it's probably going to take me a couple of weeks just as I get the registrations and everything back to you and your accreditation certificates. Okay. Thank you so much, everyone.